So good to see so many of you here again today for our second biomedicine webinar. Welcome to everyone who attended our first one. We're so glad that we can be back for a second one, and welcome to everyone who has never watched one of these webinars before. I hope you're all doing well in our second and a bit week of self-isolation. Hope you're still sane. The new season of Brooklyn Nine-Nine is coming out, or it's already out on Netflix, so I'm going to watch that soon. So I thought that we could do this session on, well, this one and the next few are going to be on cardiovascular. And this one is specifically focusing on heart failure and AAA. So we've tried to take into account as much of your feedback as we possibly could from the last session, which was, your feedback was amazing and we're so grateful for it. So hopefully things have improved. Hopefully we won't have any more technical issues, and we'll dive right into it. For those of you who don't know me, my name's Azim. I'm a recent surgical academic foundation program trainee in central London at Guy's and St. Thomas's. Biomedicine is a company that I set up with some friends of mine about a year and a half ago. And particularly during self-isolation, we're trying to help you guys out as much as we can. And all we ask for you is if you could just go and tell your friends, tell your family, tell everyone about these webinars, that would be great, because we just want to help you guys out. So great to see so many of you here. If we want to keep this as interactive as possible, so comment in the comments as much as you can, and we'll tell you a little bit about how things have changed since the last one as well in a moment. So to make a start, so our learning objectives, as I said, first cardiology topic, which you guys should have been made aware of the topics that are being covered anyway, but the first one is going to be on heart failure, and the next one is going to be on abdominal aortic aneurysms. So we're going to go through this using a case-based discussion approach like we did last time to identify our top differentials, why these are our top differentials, etc., as well as covering basic pathophysiology, diagnostic criteria, investigations, and management, etc. as well. So we have hopefully improved our interactive questioning system. So we're going to be using Mentimeter. So if you guys could have your smartphones to hand, that would be great, and hopefully this will work flawlessly. That's the plan. So that would be brilliant. And for those of you who don't know about our multi-step single best answer system, this is how we're trying to change medical education in this country, is that we believe, looking at the evidence available, that this is the best way for medical students and doctors to learn about new conditions. It follows the journey of a patient all the way from presentation to diagnosis, management, prognosis. So we'll run through those as well. And we'll make a start. So hopefully you've all got your phones to hand, and as I said, pop your questions in the comments. One thing that we are going to do differently is that your comments are all, and questions are going to be collated by our admin team, and at the end of each topic they will be sent to me, and I'll try and go through as many as I can, rather than breaking up the whole lecture into questions. But I will answer this one. Will we get the passwords to access last week's slides? So to access all our slides are available online, including the videos, including the questions and answers that we have answered for you. All you need to do is go on our website, go on the webinar tab, and put your email address in at the top of that tab, and you will get the password for free. So it's all available. You don't need to ask us for it. You just need to put the email address at the top of that page. So let's dive in. So case number one. So we have a 63-year-old lady who's presenting to her GP complaining of breathlessness while walking around her house. She's asymptomatic at rest. She does not complain of chest pain or cough and is otherwise fit and well. There she is, puffing away. Her lungs, we can see there. Her examination reveals bibasal crackles. She's got a prominent S3 heart sound, and the JVP is marginally elevated. Her ankles aren't swollen. What is the definition of a raised JVP in the relation to the sternal angle? How many centimeters are we looking? Precisely, yeah, around 3-4-ish centimeters. Great. So these are our observations. What do we think about these obs? Anything that particularly stands out at all? Yeah. I respirate, BP, brilliant. Yeah, she's got a higher, so she's tachypnic, and she is a little bit hypertensive as well. Otherwise, everything else seems okay. Good. Let's dive in to our first question. I hope this works. So have your phones to hand. So all you need to do is go to www.menti.com and use the code 438514. So there's going to be another question like this straight after this, so keep it open and hopefully this will work. Let me know if it doesn't. So the question is, in line with the diagnosis, which we already know is heart failure, what is your first line investigation? So I'll let these responses rack up. Good, I'll give you a couple more moments, see how you guys, it's a nice, easy question to ease you guys into it. All right, let's have a look. Interesting. Okay, so there's a little bit of a split here between BMP, essentially, and chest X-ray, and a few little bits, echo, D-dimers as well. So yeah, keep putting your answers in, and let's have a chat about this. So the majority of you think, you know, let's check the patient's BMP. We'll talk a little bit more about BMP in a moment. And a bunch of you think chest X-ray as well. So what we would always advise, and any clinician would advise, is to start off with your basic test first. So we have always encouraged something called the BBII approach, which we talked about last time. So bedside tests, followed by bloods, followed by imaging, followed by any invasive tests. So in terms of bedside tests, the only appropriate one really would be an ECG, which isn't an option here, but should really be done initially. We then have the option of some blood tests. So the most important blood test in suspected heart failure is going to be your BNP. We'll talk about that on the next slide. Once you've done that, absolutely, imaging is going to be needed, and the most important form of imaging initially in the acute phase is going to be a chest X-ray to look at your degree of pulmonary edema, essentially. And following that, yes, we can think about things like echoes as well. But other than an ECG, the most important next test is going to be looking at your BNP. And following that, we can think about some imaging. Does that make sense? Yeah, brilliant. Okay, so that's the correct answer, BNP. So let's have a look at the next one. So why is BNP raised in heart failure? So it's the same code, and hopefully you guys all have access to that. So we have activation of the renin-angiotensin system. There's a stretch of your atrial myocytes. There's a stretch of your ventricular myocytes, hypovolemia, or activation of the sinoatrial node. Have a think. Give you guys a couple of moments. Okay, keep your answers coming in. Okay, interesting. So the majority of you think stretch of ventricular myocytes. Some of you are still answering, but some of you think stretch of atrial myocytes, activation of RAS. So those are the three main ones. So the correct answer here is stretch of ventricular myocytes. So in patients with heart failure, these patients are overloaded. They have an increased preload, and what happens is that this then stretches your ventricular myocytes as per Frank Starling's law, which we're going to talk about, and then this causes the release of brain natriuretic peptide, or BNP, which is a natriuretic agent which actually kind of encourages your body to release sodium and water in your urine. So that is what why BNP is raised. Atrial myocytes, yes, they release some natriuretic peptide, so ANP, so atrial natriuretic peptide, and so those are the main two natriuretic peptides you need to be aware of. So BNP is increased because of ventricular myocyte stretch. Does that make sense? Move on. Okay, So now I've got a little bit of kind of warmed you guys up a little bit. Let's have a brief think about the pathophysiology behind heart failure. Now, this could literally be an 1.5 to 2 hour lecture on the Frank-Starling mechanism, so I'm not going to do that. I'm going to try and summarize this in a few sentences for you. So as I'm sure you guys are aware, so Frank-Starling came up with this law, which basically said that the stroke volume, so the amount of blood released from your left ventricle per heartbeat, will increase as your left ventricular volume increases due to myocyte stretch. So all that means is that as your preload, so the volume of blood going into your left ventricle increases, the amount of blood being pumped out by that left ventricle also increases up to a certain point. Once your myocytes have stretched so much that they can't pump out all of the fluid and blood that it needs to, then you plateau over here. And then at this point, this is when you're going to start getting your heart failure, because you've got so much fluid building up within your pulmonary circulation that it then leaks out, and it causes all your classic symptoms of the left ventricular failure. What then happens is that obviously you get this reduced ejection fraction and a reduced cardiac output. You also have activation of some neurohormonal mechanisms. The main one, guys, that I'm sure you guys are aware of is going to be the renin-angiotensin-aldosterone system. So as your heart begins to fail, these compensatory mechanisms are activated. So RAS aims to cause, vasoconstriction to try and maintain perfusion. Can you go? The rest of you guys here at all? Yeah. Okay, fab. So RAS is an example of that. So these mechanisms are initially really, really useful because they actually maintain your stroke volume. But eventually what's going to end up happening is that you're going to overload yourself with fluid because you're retaining more water, retaining more sodium, and then you get significantly overloaded. So useful initially, but actually they initiate a vicious cycle. Does that make sense? I know it's a lot of information. I tried to summarize it as much as I could. Good. So some common causes of heart failure, things like coronary artery disease, hypertension, valvular disease, atrial fibrillation. These are the most common in the UK and the developed world. So I thought I'd bring up this nice diagram here. I thought it was pretty. Let's have a look. So what I wanted to do here is try and demonstrate to you anatomically why we get the symptoms of left and right heart failure. So congestive heart failure, as I'm sure you know, is just the combination of left and right ventricular failure. So what that means is that initially your left ventricle begins to fail. You've got lots of blood coming in and the heart is trying to pump out as much as it can. It begins to hypertrophy, it begins to dilate, and there is a backflow of pressure into your pulmonary circulation. You get capillary leakage, you get increased pressure within the pulmonary circulation, and fluid begins to leak out into your lungs over here. That's when you get your breathlessness, you're puffing away, particularly on exertion. You get your orthopnea, paroxysmal nocturnal dyspnea, you're coughing up this pink frothy sputum, and your lungs are pretty awful. Now, this is when the congestive part happens. So the pressures in your lungs are building up. It causes back pressure into the right ventricle. The right ventricle is struggling to cope now, and then back pressure begins all the way back into your systemic system as well. So that's why you get up here. Here's your SVC. You get a raised JVP. Fluid begins to pool down in your legs, your peripheral edema, you get hepatomegaly. And that is why you get congestive heart failure. So right ventricular failure, secondary to left ventricular failure. So hopefully that was useful for you to get your head around a little bit more. Now, I'm not going to spend ages on this. Obviously, the slides will be released, but I thought this was a nice summary of the signs and symptoms associated with both. Like we said, your pulmonary symptoms are left-sided. You get your S3 ventricular gallop, crackles. Your stony dull percussion suggests, what does stony dull percussion suggest? Straightforward one. Exactly. So we're getting different answers. So pleural effusion, yeah. So it suggests pleural effusion rather than pulmonary edema. So fluid building up between your pleura, you get stony dull percussion, displaced apex because of ventricular hypertrophy. And then finally, right-sided heart failure causes all of your peripheral symptoms, such as ascites, hepatosplenomegaly, etc. Fantastic. All right, back onto some questions. So we've got the same lady here. She's still breathless. You can see the description of the breathlessness here. She's walking around at home, asymptomatic at rest. Which of these classifications does she fit into? Have a think and pop your answers in the comments. A, B, C, D, or E. So this isn't a Mentimeter question. Pop your answers in the comments. Never heard of this classification. That's why we're here. We can talk through them. We're getting lots of Ds, lots of Bs. D, B, B. Okay, so correct answer is B, NYHA 3. This is a really important question. It comes up very commonly in exams. It gives you a history of a patient and it says, which NYHA classification is this? And we're going to talk through this on the next slide, what that means. Anyone know what Vaughan-Williams is? Nope. Okay. So Vaughan-Williams also, yes, perfect, antiarrhythmics. So the Vaughan-Williams classification is of antiarrhythmic agents. So things like your digoxin, your amiodarones, all of those types of things fall into Vaughan-Williams. It's nothing to do with the symptoms of heart failure. So, for example, Vaughan-Williams 1 is going to be your sodium channel blockers, things like lidocaine. And then Vaughan-Williams 2 is going to be things like your anti-sympathetic nervous system, so your beta blockers, for example. So these are not related to this question, but it's very important to be aware of these. So let's have a think about NYHA then. This is your NYHA classification. It's a nice summary of it in the table. So we've got 1 to 4, and it's basically staging patients based on the symptoms that they have. So class 1 are essentially, hopefully, young people like us, nice asymptomatic people. Generally, we say no limitation of physical activity. You can climb 2 flights of stairs and be pretty much asymptomatic. We then have 2, which is a slight limitation. The mild symptoms, so maybe climbing 1 flight of stairs, you get a little bit breathless, but often you normally won't need to stop. The ordinary activity like pottering around the house, is unlikely to cause symptoms. So things like climbing stairs can do. And then 3 is a marked limitation. So you're walking around the house, you're doing your day-to-day activities, and you're getting very, very breathless. And then finally is 4, where you have breathlessness at rest, and all physical activity causes breathlessness. So this is very, very severe heart failure. So this lady fits into 3. Obviously, there's some element of subjectivity here. But the history that you've been given, 3 would be the correct answer. Does that make sense to you guys? Yes, brilliant. Okay, let's move on. So let's have a think about our investigation. So let's follow that approach. Bedside, bloods, imaging. Bedside test, like we said, ECG. So ECG, you can have evidence of left ventricular hypertrophy. So that is your broad QRSs and high amplitude QRSs as well. And then we have to think about our bloods. So this is based on NICE guidelines, so the most recent NICE guidelines. I know we have attendees from all over the world. Things are going to be very similar around the world, but this is specifically to the UK. So NT-proBNP or BNP, they're very, very similar. This is just, it's a non-active pro-hormone related to BNP. Different hospitals use different ones. So above 400 suggests heart failure, and then you need a transthoracic echo in 6 weeks. Above 2000, you need a more urgent one within 2 weeks. And then patients that present with acute heart failure need an urgent echo. So normally they present and should have one within 48 hours. When do you do a transesophageal? I'll answer that one very quickly. Transesophageal is much more specific, much more sensitive for things like heart failure, but very, very invasive. So if your transthoracic is equivocal, or you can't quite figure out what's going on, then you could consider doing a transesophageal. Transesophageals are very commonly performed during, for example, open cardiac surgery as well. So your first line is generally always going to be a transthoracic echo. Then we move on to our blood. So we're thinking about things like FBC, Usinase and renal function, and TFTs. I want to touch on high output failure just because it does come up in exams. It's a rare it's more rare than normal heart failure. Normal heart failure, we're assuming that the cardiac output is reduced, like we've described already in the pathophysiology. In high output failure, what actually happens is that it's less common, but it's usually due to an unusually high demand for the blood, for the body to pump out blood, so that your systemic organs require, for example, metabolizing more regularly, and therefore the heart needs to pump out more and more blood to maintain oxygenation and supply glucose, etc., to these tissues. So let's think about FBC. When you have severe anemia, the blood essentially contains too few oxygen-carrying red blood cells, and therefore the heart then needs to pump more blood each minute to deliver the same amount of oxygen. Then you get ventricular dilatation, you get hypertrophy, etc., and then you get overload. So like you're saying, yes, you would still get overload with high output failure, because the heart is still pumping and you're still getting that, the similar pathophysiology. Renal function, so deranged CKD, so deranged renal function or chronic kidney disease, you get retention of fluid, which then causes, your increase in preload as well. So the heart is pumping more and more to remove all of that fluid. Yeah, exactly. So similar to what Mohammed's described there as well. Then your thyroid is a similar process. So your organs systemically are turning over more and more, higher metabolic rate. So therefore, your body has an increased overall metabolism, therefore an increased blood flow to maintain perfusion. And also hypothyroidism naturally will increase your heart rate and contractility, which then causes ventricular hypertrophy and dilatation. So it's a slightly different mechanism, but it causes very similar symptoms. And then thinking about imaging, so we've got our transthoracic echo like we've been discussing. So we're looking at our left ventricular ejection fraction. So what percentage of your blood is being pumped out of your left ventricle, and a chest x-ray. So we're going to look at some chest x-rays next as well. So have that in your head. This is very straightforward in terms of investigations and very common in your exams. So as I'm sure you guys can tell, hopefully, the chest x-ray on your left is normal. Nice clear lungs, heart is of a reasonably normal size, and the run on the right is looking pretty nasty. So it's very wet. We have probably a little effusion on the left side there. You've got an increased cardiothoracic ratio as well. You've got some upper lobe diversion, but essentially this is a characteristic chest x-ray for pulmonary edema, which is actually summarized on our next slide. So here are this is the approach we like to use for pulmonary edema, ABCDE. Not sure if you guys have seen this, but it's nice and straightforward. So if we start off with A, so this is your bat wing opacity. So imagine the wings of a bat kind of flare out like this. So up here, down here, up here, down here. So you're going to expect more opacity within this region. So then I'll just answer that question in a moment. Then we have curly B lines. You can see here, these little white lines at the edge of your lung fields. Cardiomegaly, so an increased cardiothoracic ratio of more than 50%. We have upper lobe diversion or dilated upper lobe vessels. So all that means is that, so this reflects an elevation of your left atrial pressure. So as your left atrial pressure increases, just imagine that your pulmonary capillary and those vessels within the upper lobes are going to dilate to try and get all that blood from the right side of your heart to the left side of your heart, and you get diversion of blood upwards here because of that increased left atrial pressure. And then finally, pleural effusion. So normally we'd see effusions down here, but you can also see them in your horizontal fissure as well on the right-hand side here. So that's also a pleural effusion. So that's a nice summary of the chest x-ray that you would expect in heart failure. All that makes sense? Hope I'm not going too quickly. Yeah? Brilliant. Okay, let's move on. So next question, we're going back to our lovely 63-year-old lady who is breathless. What do we think is going to be our most appropriate management option? So pop your answers in the comments, A, B, C, D, or E. What are we going to do for her? B's, D's, A's. Seeing lots of B's and D's and a few A's as well. So let's have a think. So the correct answer is ramipril, D. So the first line management of heart failure, according to guidelines in the UK, is a beta blocker and an ACE inhibitor. But you shouldn't start both at the same time. So you're going to pick one, for example, either ramipril or bisoprolol. So a beta blocker and an ACE inhibitor, and you pick one, you start with one of those, and then the aim is to have dual therapy with both of those eventually. So both beta blockers and ACE inhibitors would both slow down ventricular remodeling and actually reverse it as well. So those are your two most important drugs to improve the patient's prognosis. Whereas verapamil is a calcium channel blocker, more commonly used in angina. Spironolactone is generally considered second line after a beta blocker and an ACE inhibitor. Atenolol, so that's what Serena's asking there as well. So atenolol is less preferred over, bisoprolol is preferred over atenolol. That's because bisoprolol is more cardioselective, and evidence shows that it has a greater improvement in the patient's prognosis. So that's why we generally choose bisoprolol over atenolol. And then finally, digoxin is sometimes used further down the line, particularly in patients with heart failure and atrial fibrillation. So I'm seeing all your questions, guys. So our team are going to be collecting those questions, and I'll answer them as soon as we've finished heart failure. So I'm not just ignoring you. So hopefully that makes sense. So we've started, a few months down the line, we've put her on the ramipril, we've added on the bisoprolol, and then, that didn't really help that much. So we thought, let's add on spironolactone as well. So now she's on 3 medications, and she's breathless at rest. So things have got even worse despite all of those. So here are some investigations as well. So we have ECG, which demonstrates prolonged QRS. We have an echo with a left ventricular ejection fraction, 26%. So reduced left ventricular ejection fraction. What is the most appropriate step? Now, this is a difficult question. It could certainly come up in your exams, but it's a tricky one. What do you guys think? So we're seeing B, E, A. Good. So I think lots of B's, mainly B's, E's, and A's. The answer is B. So let me explain this to you guys. So we've put this patient on 3 medications. So we've done first line bisoprolol and ramipril. We've done second line, which is add-on spironolactone. And now we're thinking, this patient is breathless at rest, so it hasn't improved things at all. You're right, the patient probably is on something like furosemide to try and provide symptomatic relief, but that isn't going to improve her prognosis. So we need to do something which is going to improve her prognosis, as well as try and relieve her symptoms as well. So yeah, all 3 of these drugs, she's using at the same time. So what cardiac resynchronization is, that essentially it's the insertion of electrodes into the left and right ventricles of the heart. So you're pacing both ventricles and forcing both of the ventricles to contract in synchrony to improve your cardiac output. So this is appropriate for patients with, who have been on a few medications, so bisoprolol, ramipril, spironolactone. If they have a prolonged QRS and a left ventricular ejection fraction less than 35%, then we're going to start them with either cardiac resynchronization or an ICD, which we'll talk about in the next slide. So you're absolutely right, it's a stepwise approach. So we've done step 1, done step 2, and now we're thinking what can help. So generally, this patient fits into the perfect category for resynchronization because they have a prolonged QRS, they have an ejection fraction below 35%, and we're essentially on 3rd line management now. So ivabradine is a funny current inhibitor. It can be used 3rd line as well. So this is what makes this question really tricky, is that this is also a viable option, but it cannot be used in patients with a heart rate less than 75. And what do we see here? A heart rate of 74. That's a very naughty question, but that is why ivabradine is incorrect. So cardiac resynchronization, verapamil, as we said before, more commonly used in angina, less so in heart failure. Cardiac transplantation, essentially last line, is not appropriate yet. And long-term oxygen therapy, there are very specific criteria for long-term oxygen therapy in heart failure patients. For example, a PaO2 of less than 7.3. This patient's saturations are actually pretty reasonable on room air, so the likelihood of that being the case is low. So that isn't appropriate in this case. So hopefully that makes sense. So how do we decide? I'll answer that one quickly just because it's a quick answer. You can pick either a beta blocker or an ACE inhibitor first, and then you just add on the other one that you haven't added on already. So hopefully that makes sense, but that's a very tricky question. So well done to all of you that got it right. So let's have a think about management. So like we said, first line, beta blocker and an ACE inhibitor, you start one drug at a time. We then want to add on an aldosterone antagonist, like we're talking about, spironolactone. And then third line, you can pick one of these or pick these. So this is a very simplified approach. Obviously, in reality, once you get beyond around second line, you're going to need the input of the cardiologist. So this is mainly just to try and simplify things for you guys for exam purposes. So once you've done the basic easy steps, so first line, second line, the patient has atrial fibrillation, digoxin, and heart failure. Digoxin is a good option. Ivabradine, if they have a heart rate above 75 with an ejection fraction of less than 35%, yes, ivabradine is a reasonable option. Now this option down here, sacubitril valsartan, this is a relatively new drug. It's also called Entresto, and it came up in, I think it was my finals actually. So they are asking about this drug now. It's a combination of what's called a neprilysin inhibitor. So that's the first word there. And valsartan, as we know, ARB. And then, so this is an option for patients with a left ventricular ejection fraction less than 35% as well. And it will normally replace your ACE inhibitor. So it's useful, but often it's going to be started by a cardiologist as well. So it's quite difficult to differentiate when to use these three. So generally, if the heart rate's less than 75, ivabradine is out of the question. If they don't have atrial fibrillation, digoxin is less useful. So generally, we're then left with these three options: CRT, ICD, or your neprilysin inhibitor here. So it's a little bit, it can be a little bit complicated to think about, but try and just separate it into these categories, and hopefully it'll be a little bit easier. So CRT, like we talked about, is biventricular pacing. And then we also have the option of an implantable cardioverter defibrillator. This is particularly for patients who are at high risk of sudden death from their heart failure. So both of these are indicated, like we talked about on the previous slide, with a QRS of above 120 and an ejection fraction of less than 35. Patient fits both of these categories. You can pick between those two. But once again, that's a specialist decision which you wouldn't be expected to make as a foundation doctor, for example. But patients with severe heart failure are at risk of life-threatening arrhythmias. That's why it's important that we also consider an ICD as well. So I know from third line onwards, it's a little bit complicated, but just try and memorize this slide and then you should be fine. And yeah, we'll take a note of that question and I'll answer that at the end. Hopefully that all makes sense. And then finally, the last thing is going to be, for symptomatic relief, you can add a loop diuretic like furosemide. But remember, that's not going to improve your prognosis. It's just going to relieve some of your edema. So that was a little bit more complicated. Acute heart failure, very straightforward. So our key concern is going to be the fact we're building up fluid in our lungs. That's the most important thing. We don't want this patient to go into severe respiratory failure. So we start off with our basic things. If their oxygen saturations are low, we give them oxygen. we want to restrict their fluid intake. This is really, really important, particularly as you go into foundation years, that patients are aware of this. Generally, this number is chosen 1.5 liters, but it varies from patient to patient. Patients that come in with acute heart failure should generally receive furosemide, which is normally as an infusion, but can be as a bolus of IV furosemide as well, just to offload and get rid of as much fluid as possible. And then we want to monitor their daily weights and urine output whilst they're in hospital. A, to see how our interventions are doing, and B, to see how much fluid is actually, how much of their weight is actually fluid and how much of it is not fluid. And then we have other options. So we're considering things like IV nitrates. Once again, there are different schools of thought about when to use nitrates, but particularly if there's hypertension with myocardial ischemia, for example, on an ECG with T-wave inversion, often nitrates are given then. If patients are really hemodynamically unstable, we can give an inotrope like dobutamine that will essentially force your heart to pump harder to improve your ejection fraction, just so they don't go into a cardiac arrest. And then finally, if all of this isn't really working, you can think of non-invasive ventilation. So normally CPAP for type 1 respiratory failure. And then if all of that fails and the patient's still deteriorating, then we may need to intubate and ventilate. That's pretty straightforward. Think about your conservative management and then what drugs you're going to give and how you're going to ventilate this patient. Does that make sense to you guys? I hope I'm not going too quickly. Brilliant. Good, I'm glad. So I think it's one of our last questions on heart failure. So this lovely lady, she came in, we've helped her out, we've given her lots of drugs, we've put in CRT, she's on CRT now. What are we going to do in the long-term management of this patient? What do we think? C, 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 C. Good. That's brilliant. Well done, guys. So loads of you know that. So yes, so make sure that you remember this. We want to give the annual influenza vaccine and a one-off pneumococcal vaccine. This is the current NICE guidelines, and mainly because patients can be at increased risk of these infections, but also the most recent evidence suggests that actually, if you get, particularly influenza, if you have heart failure and you get influenza, it increases the risk of actually getting atheromas. It depresses the contractility of your heart and actually increases your overall cardiovascular mortality, which is super interesting because you wouldn't think influenza can cause an increase in your specific cardiovascular mortality, but that is what our evidence actually shows as well. So that is why we give the annual influenza vaccine and a one-off pneumococcal vaccine. Brilliant. So well done, guys. That was a crash course on heart failure. If you learn all of that, you'll be absolutely fine in your exams and you'll smash it. Brief summary here is congestive heart failure, like we know now, is a combination of left and right-sided heart failure. So you get both pulmonary edema and congestion and peripheral edema. These are our most common causes. On examination, these are the types of things we're looking for. Remember that table we looked at? Try and split it up and think, why am I actually getting an S3 heart fat sound? Oh, it's because, my left ventricle is more compliant. So now I'm getting this ventricular gallop. So try and think of the pathophysiology behind all of these signs. And that's something we'd really encourage you to do regardless of, whichever specialty you're studying. Is try and think, why am I getting biobasal crackles? Why are all of these things happening? And that will make you like a much better doctor. And then the NYHA is commonly used, the scoring criteria like we were talking about of your symptoms. We know our first line management, and then our further management can get a little bit more complicated. You often need input from your cardiologist about things like ivabradine, digoxin, CRT, and an ICD. Brilliant. So that is heart failure in a nutshell. And I hope that was useful for you guys. So let's move on to the Q&A. So I'm hoping my team has sent me some of the questions that you guys have asked. So I'm just waiting to receive that. I'll answer this one here at the top at the moment. So how does an S3 heart sound occur? So like I said, it's an it's a ventricular gallop, which means that when your left ventricle is more compliant and dilated, it's essentially the sound of all of that blood hitting a dilated ventricle. So that's why you get an S3 gallop. Got another question, here we are. So which echo would you do for suspected heart failure? So generally first line is going to be your transthoracic echo. Lots of questions. So how would right-sided heart failure lead to hepatosplenomegaly? So you've got right-sided heart failure. There's then going to be back pressure of blood into your SVC and tracking all the way down your IVC towards your portal system. So what eventually is going to end up happening is when you get really severe right-sided heart failure, all that back pressure is going to end up being, diverted all the way down into your abdomen. This can cause an increase in your portal pressures as well. This then causes your, like we're talking about, an enlargement of your liver and an enlargement of your spleen as well. How does CKD cause heart failure? I think we answered that previously. Would you still get overload in heart failure? Yes, I think we discussed that as well. If it was an acute presentation of heart failure, would she be given furosemide first to relieve symptoms? So in an acute presentation, particularly if a patient is significantly breathless, very short of breath with difficulty breathing, absolutely we will give normally an infusion of furosemide or at least a bolus of IV furosemide. Would ivabradine be preferred over CRT if the heart rate is more than 75? Brilliant question. Hypothetically, yes, because you're not going to need to actually implant electrodes. You're not going to actually need to do anything particularly invasive. So on the whole, probably yes, but once again, it varies in terms of cardiologists, and there are no strict guidelines regarding that. How long do you wait before you add the next agent for the first line dual therapy? So once again, no hard and fast rules about this. It's more just the fact that both ramipril and a beta blocker can drop your blood pressure. So, I mean, I think, a 2-week trial on one of them and then starting the next one, making sure the patient is stable would be reasonable. But once again, there's no exact period for that. How do you know if a patient is at high risk of sudden cardiac failure or life-threatening arrhythmia? So ICDs are particularly preferred if patients are going to be at high risk of sudden cardiac failure, so or a life-threatening arrhythmia. So generally, that would be those patients that have a prolonged QRS with a reduced left ventricular ejection fraction. So those two criteria will put them at higher risk, and that is why at that point we would consider an ICD or CRT, because by definition, having those two things increases your risk. I'll try and answer one more. What's this one? How do you calculate cardiac output? Okay, so cardiac output is your stroke volume times your heart rate. So normal stroke volume for a 70-year-old fit person is going to be 70 mils, and then you times that by your heart rate, and you get your cardiac output. So I've tried to answer as many as I can there. What we'll do is all the others that we've been asked, we're going to put it into our PDF, which is going to be uploaded for free onto our website. We'll be able to answer all of your questions. So hopefully that was useful for you guys. And we will move on to our second case. Good, no problem. Thank you. Thank you for keeping up. So our second case. So moving away from heart failure now, we have a 62-year-old male who's presented to the emergency department with your diffuse central sudden onset abdominal pain with back pain. There he is. He's in some pain. What are we going to do? So have a think. So he has a 20-pack-year smoking history. He's on irbesartan, but he's not sure what for. He's visibly in pain, but has a nice soft abdomen, but has generalized tenderness. So we already know the diagnosis because, we revealed that at the start, but I have to think about what other differentials this could potentially be. Let's have a look at our observations. What stands out in terms of the observations here? Low BP, agreed. Hypertensive, yeah, and high rest rate. Absolutely, those are probably the two biggest things. There's a little bit tachypnic and he's got a low blood pressure. So I guess alarm bells should be ringing for various different things here. he's got cardiovascular risk factors. He's on irbesartan, which indicates he probably has high blood pressure potentially. He had a prolonged smoking history as well. So we're thinking, what could be causing this? Now, obviously, we know that this is a AAA because that was revealed at the beginning. But one thing I really want to stipulate here is that often these patients get missed. I've seen, working in A&E in central London, patients with leaking AAAs or even ruptured AAAs being mistaken for things like renal colic, being mistaken for things like exactly acute pancreatitis. So I once had a urology job where a patient was transferred from A&E to the urology ward with renal colic, was being treated for renal colic, and turned out he had a leaking abdominal aortic aneurysm, which eventually ruptured, and he died. So we have to always think about, could this be a AAA? And yeah, this comment here, he's likely to be a vascular pathogen, he's likely to be hypertensive. So it's even more worrying that he is hypotensive when he's normally hypertensive. So that's even more worrying. All of that makes sense. The key point here is don't miss this diagnosis. So hopefully this works. Let's have a look. So get your phones out for me and let's have a think. What's the most common site for an abdominal aortic aneurysm? Once again, a common exam question because it's testing your anatomy as well as your clinical expertise as well. So yeah, go to menti.com and type in that code. It's a tricky question. Says not open. So the answers are coming as a try again, menti.com 736958. Sorry, yes, I wasn't aware that's a new code, yeah. Good, okay, let's see what you guys are thinking. Okay, a few different answers. So it looks like the main split is between infrarenal and suprarenal. Correct answer, infrarenal. So almost an identical split between the two. Really, really important thing to remember. So infrarenal aortic aneurysms. So let me break down all of these. So an infrarenal aortic aneurysm is an aneurysm, so a bulging in your abdominal aorta, which occurs below your renal arteries. I'm going to show this on the next few slides as well. This is the most common and generally the easiest to fix as well. Suprarenal occurs above your renal arteries. Pararenal is actually a more general term, and it's actually split up into juxtarenal and suprarenal. So yeah, juxtarenal is around the actual or adjacent to the lower margins of your renal arteries. But the main point to remember here is that infrarenal, so below your renal arteries, is the most common. Common iliac, this would be an iliac aneurysm and doesn't actually classify as an abdominal aortic aneurysm. Does that make sense to you guys? Yeah. Okay, good. Move on. So let's have a think about our pathophysiology now. So this image here shows your classic infrarenal abdominal aortic aneurysm. So you've got your renal arteries poking off here, and it's below that. So this is the most common. An abdominal aortic aneurysm is dilatation in that vessel wall of beyond 3 centimeters. Commonly infrarenal, as we said, and these are our key risk factors. The first, probably 2 are the most important: so smoking, hypertension, as well as being male, and connective tissue disorders. Any particular connective tissue disorders that you guys know of that increases your risk? Marfan's, Ehlers-Danlos, exactly. So both Marfan syndrome and Ehlers-Danlos increase your risk of abdominal aortic aneurysm. It occurs because of a degradation of your tunica media and adventitia. And also in terms of pathophysiology, atherosclerosis and the production of collagenases, which break down collagen, causes that abdominal aortic aneurysm to grow and grow and grow. Now, this is a subtype which I thought it would be important to mention very briefly. So up to 10% of AAAs are actually inflammatory in nature. This means that the underlying pathophysiology is inflammation. Now, it's a little bit unclear in terms of pathophysiology why this happens, but more commonly occurs in younger patients who smoke and may have some atherosclerosis. And often patients will also present with a fever. And it often is also managed with steroids rather than surgery. So it's just something I wanted to mention in case in your exams you have a young patient with a fever, with a presentation similar to a AAA, you could think, actually, you know what, is this an inflammatory AAA? But I wouldn't worry too much about going into the details of that. Brilliant. So we put this in because we thought this looked super cool. So as you can see, here's a 3D representation of your aorta. At the top here is your thoracic and ascending aorta. And then you've got your descending aorta here. And this big bulge here, this is an infrarenal abdominal aortic aneurysm. So I'm not sure how much anatomy you guys remember, but you have your celiac trunk up here. You have your superior mesenteric, and then some renal arteries poking off around here. And that's where the aneurysm is. And then, yeah, and these are your common iliacs. So that's a, try and have that image in your head as well. So back to our multi-step SBA. So we have this 62-year-old chap. He's in A&E. These are his observations, which we've looked at already. What do we think? A, B, C, D, or E? What is our best first step? Nice, straightforward question. Good, good. Couple of C's, but mainly D's. Absolutely, brilliant. Abdominal ultrasound, first line investigation. Now, I know that we said follow the bedside blood imaging approach. Technically, yes, you should, but also technically this is a bedside test. It's quick, it's easy. If this patient has a AAA, which is leaking or ruptured, it's a surgical emergency. So you have to then switch that algorithm around a little bit and prioritize the things that you need to do first. Abdominal ultrasound, high sensitivity and specificity for picking up abdominal aortic aneurysms. CT abdo-pelvis is brilliant as well, but you know, the first line, because it's quick and easy and a bedside test, is going to be an abdominal ultrasound. Good. So investigations, bedside, abdominal ultrasound, technically also fits into imaging as well. Bloods. These are the most important bloods you need to do. The full blood count, if you have a leaking AAA, it can cause anemia. If it's ruptured, often your HB may be actually borderline normal because acute bleeds can take some time for your HB to drop. You need your renal function, partly because you need it for your CT angiogram and partly because if it has ruptured or leaked, then you can get hypovolemia, which can cause a pre-renal acute kidney injury. Check your inflammatory markers. You know, could this be an inflammatory AAA? It's always worth checking. And then really, really important is your group and save and your cross-match. So patients, particularly if ruptured, are going to need to be rushed to theatre ASAP. Your job as the junior doctor is to make sure that patient has everything they need to be optimized for surgery. Particularly as an F2, for example, in A&E, that's going to be your role. If you think there's a ruptured AAA, then you know your consultant is going to say, you know, we need to get this patient to resus. Your job is to, you know, prep, inform the vascular surgeons, make sure they're prepping for theatre, make sure they have group and saves and cross matches so that blood is available if they need transfusion, which they inevitably will. So never ever forget that. Commonly, junior doctors will forget to do that, and then that causes massive problems. What is group and save? Group and save is checking the blood type of the patient. So sending a couple of samples of blood to the bank for that patient. They they take those samples, make sure that, you know, there's nothing nasty in there, and they check the blood type. Cross-matching is then actually preparing those units of blood for when the patient needs them. If the patient's bleeding out, they need blood. If the patient's being prepped for a big operation, they'll need blood. So then you say, okay, blood bank, do you have the blood group and save? Do you know the type of blood? They'll say yes. Then you'll say, okay, I need 6 units ASAP because we have a ruptured AAA. So it's more like preparation and then action plan. Further imaging is your CT angio. This is going to be your most important diagnostic test. And as you can see here, this is your bulging of this is your infrarenal abdominal aortic aneurysm. So that's what it looks like, lateral view of a CT angio. Good. Hope all of that made sense to you guys. Investigations for it are actually pretty straightforward. So let's have a think about the next thing. So this patient has come in. We are, having done an ultrasound. What is the actual threshold for referral to vascular surgery? D, 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 B, A, B's and D's. The answer is 5.5 centimeters. Have that number glued into your head. Now, the main point with abdominal aortic aneurysms that you need to the thing you're trying to do is obviously any operation is associated with risk. You want to operate on the patient once the risk of rupture and death from rupture is greater than the risk associated with operating on them. If you operate when it's 4 centimeters, 3 centimeters, the risk of rupture is relatively low, but therefore their risks of having the operation are actually going to be higher than the risk of rupture. So that's why the evidence shows that this number is perfect, 5.5. So a little bit about management. So there are a few options. So surveillance. So this is for asymptomatic aneurysms less than 5.5 centimeters on ultrasound. So this patient, you can't, he's symptomatic, so you can't just have surveillance. Elective surgical repair is for large, so more than 5.5 centimeters, asymptomatic aneurysms. And then urgent surgical repair, which this patient will require, is going to be for a ruptured or symptomatic aneurysm. So this is going to be the main things you need to remember. I'm seeing questions about screening program. In a couple of slides, we're going to break down the screening program for you guys as well. So this is the main thing. If it's symptomatic, they need to be repaired urgently. If they're large and asymptomatic, they can be electively repaired. And if they're asymptomatic and less than 5.5 centimeters, you can undergo surveillance. A couple of surgical options to be aware of: open and endovascular. Open, as it sounds, pretty straightforward. Endovascular is the insertion of a stent. So this diagram on the right shows a stent for an infrarenal abdominal aortic aneurysm, minimally invasive. So it has, both are actually associated with similar outcomes in terms of mortality, but open repair has higher complications in terms of bleeding and infection around the operative period, whereas endovascular has higher complications later on. So you can get leaks around the stent, you can get infected stents, you can get migrated stents. So the long-term complications are higher now. So yeah, hopefully that makes sense. The choice between the two often is dependent on the surgeon and which one they feel more confident with. But EVAR is increasing in the developing world and the developed world. Good. So these are the screening guidelines. Memorize this. Know those numbers off the top of your head. Very, very common question. So screening guidelines, main thing to remember as well is that it's offered to all males aged over 65 as a one-off abdominal ultrasound. You do one ultrasound at around 65 years old or older. You have a look at the size of the aneurysm and you act accordingly. Either discharge them, you want to do surveillance annually, you want to do 3-monthly surveillance, or refer to vascular surgery for them to consider surgery. And often endovascular approach is more appropriate for kind of comorbid elderly patients as well, who may not survive an open operation. So I just thought I'd mention that. Does all of that make sense so far, guys? I know there's a lot of information. Yeah, brilliant. If you know all of that, that is a lot more than most people at medical school will know about abdominal aortic aneurysms anyway, so that's brilliant. So as we come to finish off, last few minutes, complications of abdominal aortic aneurysms. Most important one is, of course, rupture. Surgical emergency. These patients need to be treated ASAP. Another one, which is really, really interesting, is thromboembolism. So you've got an aneurysm, a thrombus can form, and this can actually embolize to distal vessels. And yes, sorry, I would like to clarify, in terms of the screening program, which we were just looking at here, this is for the general population. So anyone in the general population that fits this criteria will need it, not just those attending hospital, exactly. Sorry, yes, complications. So one thing to remember is that you can actually get emboli forming from a thrombus around the aneurysm. This can then actually present with things like, leg pain, thigh pain, because, you've got clots being thrown up to your legs. So that is how patients can also present as well. You can get the formation of fistulas. So, for example, a fistula between your massive aorta and your gastrointestinal tract as well. Just be aware that is a possible complication as well. And then ureteric obstruction. Remember, your ureters are relatively close to your abdominal aorta. The abdominal aorta gets bigger and bigger and bigger. It can actually compress those ureters, and patients can present with symptoms almost identical to renal colic, because this aneurysm is compressing your ureters. Those are the main complications to be aware of. Brilliant. So, summary of abdominal aortic aneurysm. This must be probably one of your top differentials with any patient, particularly male above the age of 60. Bedside ultrasound, most important test, along with those blood tests that we were talking about. 60 or 65, so 65 is going to be your screening, but we would recommend any patient over 60, any male particularly over 60. You need to consider abdominal aortic aneurysm. And in A&E now, we also do fast scans, ultrasound scans, really for any patient that presents fulfilling these criteria. You want to consider surgery if your diameter is above 5.5, and then your EVARs are becoming more and more common as well. So your endovascular aortic repairs. Remember, if there's a ruptured AAA, not vast majority, but a massive proportion will die before they even reach you in hospital. If you have a ruptured AAA and they're alive, your job, along with the rest of the team of the junior doctors, to try and keep them alive to theatre. Good. So let's have a think of the questions that you were asking. Let me have a look. Hopefully I can answer these. So, how often would you see visible pulsation in a AAA? So I'm sure you guys know, when you're taught at medical school, you're taught, normal abdominal aorta is pulsatile but not expansile. In reality, it's difficult. It can be very, very difficult to tell. So it's difficult to come up with a precise percentage. But I would rely more on the history and observations, particularly for diagnosing a AAA, even more so than whether the abdominal aorta is expansile or pulsatile. Do you act if they're symptomatic but below 5.5 centimeters? Yes. Any patient with a symptomatic AAA, they're very unlikely to be symptomatic if their abdominal aorta is small. But if they have an abdominal aortic aneurysm and they're symptomatic, they will need surgery. You shouldn't discharge a patient with a diagnosis of a AAA who is symptomatic. How long does it take for blood to come after requesting group and save and cross match? It can take time. It takes time to take the blood. It takes time to get to the bank. So often in my, obviously Guy's and St Thomas's is central London and very well equipped. It can take an hour, even a little bit more sometimes. So I think, the next question as well is about group, O negative blood. If there's a rupture, they're hemodynamically unstable, this patient needs to go to theatre, put out a major hemorrhage protocol as per your local guidelines. That will get that'll get O negative blood available immediately. But if not, then, and you can, wait around a little bit for an hour or so, then you can wait for your group and save and cross-matched blood, which is generally preferred. Are there any plans to screen women? Not that I'm aware of right now, mainly because the risk in women is significantly lower than in men. What symptoms would the patient present with in a symptomatic AAA? Essentially exactly the case we just described. Abdominal pain is classic. When it's ruptured, then we're thinking about things like, hemodynamic instability, syncope, for example. Yeah, I think those are probably the main ones. There are a few here which are a little bit more complicated, which we're going to answer in the PDF because they need a slightly longer explanation. I'll see any other questions that you've got here. If a AAA is picked up on abdominal ultrasound, do you need a CT? So in a ruptured AAA, the patient is hemodynamically unstable. The priority is to go to theatre. You can have an open abdominal aortic aneurysm repair without a CT angiogram. The big bonus of it is that it can happen really, really quickly. If you're going to plan to an endovascular aortic repair, you need a CT because you need to know the precise anatomy, because you're putting up catheters, you're putting up stents and things. So that's the main point there. And I can probably answer one more. When is the fast scan carried out? This is carried out mainly for trauma. So for example, stabbings, road traffic accidents, to see if there's any free fluid in the abdomen, for example. But it's just an ultrasound, essentially. It's just got a fancier name. But almost every A&E registrar is able to do a fast scan. So thank you so much for listening. I really, really hope that was useful. Thank you so much. The most important thing that we could have from you guys, if that's okay, is your feedback would be so, so useful. We were trying to improve these as much as possible. I'm going to put the link in here. Let's give it a go. No, thank you guys. Thank you. If you guys could just please tell your friends about it, that would be brilliant. We're just trying to help out as many of you guys as possible. Let me try and paste this link here. It's not even working. It's weird. Thank you so much. Yeah, if you follow, there's the link. Yes, thank you. If you guys could fill out this form, that would be super useful. We have our new website coming soon. All of this is available online on our website. Please follow us on Instagram, social media. You can buy our textbook as well, which is also on our website, www.biomedicine.com. And also, if you're interested in working with us and participating in teaching, then get in contact with us. We have a whole editorial body. We have medical students across the country working with us. So that would be really useful. It says link not found. That's not great. If you could scan the QR code, that would be brilliant. Link not found. QR code works. Let me see if I can give you guys the link. Or if someone else in the team is here, that would be great. If they can send the link, that would be brilliant. Thank you. That's the one. Hopefully that works. Yeah, please, if you want to join and help, pop us an email, admin@biomedicine.com. We'll give you stuff for your portfolios. We will give you feedback forms, certificates, whatever you guys can do to help out. But yeah, I mean, all of your input is brilliant. Your feedback is really, really useful. We're going to keep doing these. Hopefully you've all seen the schedule on our Instagram and Facebook. So the schedule for the next couple of weeks. We're increasing these to twice a week now as well, based on your guys' feedback as well. The schedule's not on our website right now, but it's on our Instagram page, which is @biomedicine, as well as our Facebook, which is on the link on the screen. Yeah, so yeah, your feedback would be brilliant. Any other questions, shoot us a line. And then also, like Zach is saying here, one of the admins, we are developing a new website to kind of change and revolutionize medical education in this country, because we think it needs an overhaul, essentially, which is coming out in 2 weeks, which will have all of these webinars and so much more on that website as well. To get the slides, go on www.biomedicine.com and click the webinar link at the top of the page. This will take you to all our PDFs and videos. And then all it asks is you to enter your email address at the top, and you'll get the free password protected files. So yeah, I think I'll finish off there. Thank you so much for staying around till the end. We'll keep up this format, and any feedback that we get, we will change up depending on what you guys want to change.